Professor Bernardo. We are sorry, just we are facing a delay, so we are waiting for our chairpersons to arrive.
Okay.
Okay, so everything is set and the PowerPoint is perfect. We are just waiting.
Yeah.
Okay.
So I will be the first one to talk in this session?
Yes, Professor.
Okay, perfect.
Okay.
Okay.
Professor, we are ready to start.
Okay. I cannot see you actually.
Doctor.
Hello? May I ask you a question?
Hello. You have the pleasure of presenting Mr. Fernando. Actually, he will be offering us to talk about coating balloons and delivery lesions. He can start. Can
Hello?
you hear me now?
Yes.
Yes, I do have the pleasure of presenting. I'm going to re-present because the mic was not on. Professor Bernardo from Italy. He will be kind enough to offer us a presentation regarding drug coating balloons in de novo lesions. Hope we'll enjoy it. Are you ready?
Yes. Hello, everybody, and good evening. I'm Dr. Cortese from Italy, from Milano. Really happy to be here after 1 year, even if it's not in front of you, but the topic is still hot. I have some updates to give you about the use of drug-coated balloons in de novo lesions. So I'm ready to start. This is my potential conflict of interest. And I would like to start from this slide, which clearly shows how, especially in small vessels, the rate of target lesion failure with currently available DES is still high. You can see here on the left top panel that if you implant a DES, a current era DES in a small vessel, you still have a rate of target lesion failure, which is quite high, 9.5% after a few years. And again, the rate of target vessel myocardial infarction and the target lesion revascularizations are higher than in other vessels, like larger vessels, where the target lesion failure after a few years is 5.4%. So the topic here is, may I use an alternative to the drug-eluting stent, especially in small to mid vessels? And I would say yes. This is a case of a total occlusion treated by means of drug-coated balloon. Here, a magic touch balloon was used at 2.5 by 40. After pre-dilatation, we treated this total occlusion with a long drug-coated balloon. This was the final result. We did not implant a stent, also because after a recanalization of a CTO, we know that it's not easy to know very well the correct vessel size. And the advantage with a drug-coated balloon is that you will not encounter late malapposition. And you can see here after 6 months, the same patient, the same lesion, there was an improvement in the lumen. So a lumen gain is achievable by means of a drug-coated balloons, but not by means of a drug-eluting stent. So this is a possible application of a drug-coated balloon. One of the possible problems that are shared is the final dissection. Many physicians are asking me, okay, but if I have a dissection, what can I do? We can have some answers from Paclitaxel. Here we left 52 patients with a final dissection. 4 of them were treated with a stent and 48 without any additional stent after drug-coated balloon PCI. And after 6 months, 45 out of 48 dissections left were totally healed, and there were no thrombotic issues, no acute vessel closures. And you can see here that the clinical outcome was very similar to a cohort of patients treated by drug-coated balloons, but without any dissection left. So leaving a dissection, which is not flow limiting, currently is safe after DCB use. We have some very recent data. This is the DCB RISE registry done with the Elutax SV and or Emperor, also called Emperor DCB. And here in de novo lesions, the rate of TLR was very low, 2.6%, and the total Doce rate is 2.6% after 1 year. This is another device, a randomized clinical trial, small vessel disease, and here patients were randomized to Resolute DS and Restore DCB. In this study, the primary outcome was similar between these two devices. In a small vessel setting, 29.6% was a person diameter stenosis in the DCB group and 24% in the DES group, which was similar and non-inferior in the DCB group. And after 2 years, these data were presented during TCT last year. The rate of cumulative events was quite similar between these two devices. Then we have the largest study done in a small vessel disease setting, basket small 2, sequent please, DCB, eluting paclitaxel, which was randomized to Taxus element for about 25% of the patients and the rest treated with the Xience DES. Here, the non-inferiority was hypothesized between these two devices, and the sample size was calculated according to a primary clinical endpoint, which was MACE. The cumulative rate of MACE after 12 months was quite identical between these two devices, slightly more than 7% between sequent please and the DES. And if we split the outcome according to the device which was used to treat the patients, and we just analyze Xience versus sequent please without any further stent implantation, you can see here that the clinical outcome was very good and was similar again between these two types of devices. And the most recent study is the Paclitaxel 2, which we presented during TCT last year and which will be published soon in JACC Interventions. This multi-center study had the aim of analyzing the outcome, hypothesizing the non-inferiority between Elutax Emperor versus Xience in small vessel disease up to 2.75 millimeters. We randomized 232 patients one-to-one between these two devices, and we have the primary outcome, which is an angiographic outcome after 6 months in about 90% of the patients. Primary endpoint in this study was late lumen loss. Late lumen loss in Xience was 0.17, which was pretty good in this setting, whereas it was 0.04 in the Elutax SV group. So there was non-inferiority, but there was also superiority in the DCB group versus Xience in terms of angiographic endpoint, late lumen loss. And the rest of the angiographic endpoints, which were binary restenosis and percent diameter stenosis, either in lesion and in segment, were quite the same between these two types of devices. And this is the behavior of some of the available angiographic data in the DCB group. And you can see here that the Paclitaxel 2 with Elutax is working very well with 0.04 millimeters of late lumen loss. About the clinical outcome, there is no significant differences between Xience and Elutax and Emperor in terms of MACE, myocardial infarction. There was a non-significant reduction in the DCB, TLR, and TVR. But the question is Paclitaxel harmful? After the meta-analysis of Katsanos, there were some doubts which were raised. We have seen with this meta-analysis of paclitaxel-coated balloons and DES used in the femoropopliteal artery that there was an increase in mortality after 2 years and in a few studies after 4 to 5 years. However, there was no mortality signal in terms of this endpoint after 12 months between the two groups. Well, we know quite well that paclitaxel added to a stent is not doing a very good job. We have seen with the Taxus that the thrombotic risk is a little bit higher than other DES, and also the risk of apposition of fibrin, of thrombus, even if asymptomatic, is higher with a paclitaxel-coated stents. So metal plus paclitaxel is probably not good. However, in a post-hoc analysis done by the FDA, there was no single increase of mortality, of any type of mortality in patients treated by paclitaxel if compared to patients not treated by paclitaxel. We have discussed about the results of this meta-analysis in several papers, and we have to conclude that there were severe methodological deficiencies in this meta-analysis if the goal was to say that paclitaxel is harmful for the periphery. There was no patient-level data. There were merged stents and drug-coated balloons together, and there are no long-term data. Only 10% of the patients treated with this device had a 4 to 5 year follow-up. So the conclusion of this meta-analysis is not conclusive in our opinion. We have also this meta-analysis done in the legs, which shows that there is no increase in mortality after paclitaxel applications by means of the dosage of the drug. And quite the same, there is a reduction in mortality in this meta-analysis when we analyze the outcome of PCB in the coronary tree.
We lost your voice for a minute,
okay,
but you're back now.
Yeah, so I was just saying that there is no signal of increased mortality, but there is a strong signal of reduced mortality when you use a paclitaxel-coated balloon in the coronary tree as compared to other treatment options, like this meta-analysis of Bruno Scheller is clearly showing. However, here we also have an alternative to paclitaxel. We have sirolimus. I'm not going to show you the mechanism of sirolimus, which you know quite well. We know that the therapeutic window of sirolimus is much higher than the one of paclitaxel. However, the tissue absorption and retention in the vessel wall is lower. So you need a different technology when you want to use a sirolimus-coated balloon. Currently, there are 2 sirolimus-coated balloons which are marketed in Europe. And the first one is the Magic Touch, which is showing some preliminary, very good data in terms of late lumen loss. Here is the study which we published last year, 27 consecutive patients, core lab analysis, and what we have seen is that the late lumen loss was 0.09 in this SCD group of patients. We also have some data about with the clinical endpoints, which are provided by ISMO registry, which is a worldwide registry, still ongoing. We will reach 2,100 patients. We are very close to the goal of finishing the enrollment of this registry. We are just very close to this final goal. And we have the interim analysis after 12 months, 600 patients, the rate of total death, MI, TLR, and MACE were quite good. And what about a comparison between sirolimus and paclitaxel? We have the CIRPAC study, which is an investigator-initiated study. We are here comparing the results between the DCB RISE, Elutax SV group, 544 patients, and the ISPOR interim analysis, 596 patients. We have the 12-month clinical follow-up data. Primary endpoint is the 12-month MACE rate. And out of 1,100 patients, we have obtained, after propensity matching, 2 groups of 290 patients. And the outcome of this study, of the CIRPAC study, we are presenting during EuroPCR this year. We have a total non-inferiority between paclitaxel and sirolimus. MACE rate was 10%, TLR was 8 and 8.3%, MI was similar. So no differences in terms of any clinical endpoint and any cumulative endpoint between these 2 types of device after 12 months. So in conclusion, Cazzano's meta-analysis was an earthquake on the field, but was flawed by major statistical drawbacks. We have some biological plausibility, especially with the first generation paclitaxel-coated balloon. We totally share that the latest generation paclitaxel-coated balloon are much better than the first generation, especially if you don't apply a stent after using this type of device. On the other hand, we have the sirolimus, which is a good alternative, and the preliminary data provided by sirolimus currently are very good. So we can decide either to use a sirolimus-coated balloon or a paclitaxel new generation 1 to treat our native vessel disease patients. Thank you for your attention.
Professor Cortez, I would like to thank you very much for this interesting lecture. I do have a special interest in drug-coating balloons, and I've been using it for the last 8 years. I was excited when I was working in UK last winter by the introduction of the Magic Touch, and I had few opportunities to have first-hand use of it, and I did like it. I would like to thank you for sharing with us the results of the Basket 2, Picolate, and the exciting back. I would like to ask you, bearing in mind that the Greek, as you know, have shown us 2 studies with increased mortality of using paclitaxel, would it matter to you if you use paclitaxel or sirolimus nanotechnology like Magic Touch? Would it make any difference to you? What about the feeling of it? I mean, I felt personally that the Magic Touch was not as cumbersome and as bulky as the paclitaxel coated balloons. I just need to know your own feeling and your comments. Thank you.
Yes, this is the point. To our knowledge, the clinical performance of sirolimus by means of Magic Touch and currently available, some of the currently available paclitaxel coated balloon are quite similar. The 2 drugs are not harmful, they are safe, and they are effective. However, currently there is an advantage in terms of trackability and deliverability with the Magic Touch. I have to tell you, we use Magic Touch in about 40 to 50% of our PCIs with the DCB, and trackability of this device is pretty much improved as compared to the paclitaxel ones. I know that there are other new devices which will come into the market with paclitaxel, and hopefully they will improve the deliverability of their device.
Thank you very much. Any comments from the audience? Any comments from chairpersons? Thank you.
We thank the previous speaker, Dr. Bernardo Cortesi from Italy, and now we move to the UK.
Doctor, can you hear me?
Yes.
It gives me great pleasure to introduce the next
Can you open
speaker,
your
who's a
presentation?
personal friend, and he's a world-renowned cardiologist and also a world-renowned researcher. He's a professor of interventional cardiology in the UK, and he's going to talk to us on PCI and high bleeding risk patients. Professor Mamas.
So thank you, Hani, for your very generous...
Mamas, can you hear us?
Yes, can you hear me?
Hi, it's Hani Raghi here.
Yes, hi Hani, how are you? So